The Schneider School is a leader in talent development for business in our region, providing world-class programs for our undergraduate and graduate students and resources like the Center for Exceptional Leadership, the Center for Business and Economic Analysis, and the Strategic Research Institute. The Schneider School is about sharing business intelligence and the people who are shaping our economy. You and our speakers are integral members of that group, so thank you for being here. We are now in the 22nd year of the CEO series, providing area executives with an opportunity to hear from some of our top area CEOs. This resource is brought to you by the generosity of our presenting sponsor, Myron Construction, title sponsors, Johnson Financial Group, David Kelthal, Attorneys at Law, and Insight Publications. Today's session is sponsored by our friends at J.P. Morgan. This series couldn't be possible without the support of our sponsors, so please join me in giving them some recognition. Thank you very much. So at the moment, I stand between you and breakfast, so I'm going to ask Father Anwu Akpa to offer grace. Father Anwu was born in Nigeria, where he studied as a seminarian with the Claretons and the Missionaries of Africa. He moved to the United States in 1998 at the invitation of the Norbertines, where he has lived and ministered with the Norbertines in Mississippi for the greater part of his life. In his free time, Father Akpa enjoys watching soccer, or what we refer to as football, right?
Good morning, everybody. I would like to begin this short prayer with a reading from the Gospel according to Matthew chapter 18, verses 19 to 20. Again, I tell you truly that if two of you on the earth agree about anything you ask for, it will be done for you by my Father in heaven. But where two or three gather together in my name, there am I with them. Loving Father, we come before you in gratitude for all we do to create a better society. Make your presence sufficient enough for us. We make our prayer through Christ our Lord. Amen.
I want to say thank you to our servers and dining staff for that delicious meal. So if you join me in a round of applause for those folks. Thank you. It's now my pleasure to introduce Chris Woleske, President and Chief Executive Officer of Bellin Health. As a member of the executive leadership team at Bellin for more than 20 years, she's been involved in strategic planning, strategic relationships, and operational execution of Bellin strategies for Bellin Hospital, Bellin Medical Group, Bellin Psychiatric Center, and Bellin Health, Akanto Hospital. Chris is the past chair of the Greater Green Bay Community Foundation Board, where she led initiatives to improve health by addressing the underlying social determinants of health. She's a member of the Wisconsin Hospital Association Board of Directors and Kruger International, Inc. Board of Directors. Chris is a fellow of the American College of Healthcare Executives. She earned her bachelor's degree of science in healthcare administration from the University of Wisconsin-Eau Claire, her law degree from Marquette Law School, and completed the Stanford Graduate School of Business Executive Program. Today, Chris is presenting her topic, Medicare for All, so please join me in welcoming the President and Chief Executive Officer of Bellin Health, Chris Woleske.
So I'm told that this is a large crowd for these breakfasts, and I'm really glad that Lisa didn't tell me that before I got here this morning. I also want to disclaim selecting this as the content for today. I'm going to give that to Dean Thank you very much. I asked him, so how did this even start? When did we start talking about this? It was in the spring, so it wasn't quite as hot of a topic then as it is now. And I don't know why I ever agreed that this could be the topic, but I did tell Therese Pandel that all of the difficult questions are going to her. So thanks everybody for coming, and thank you also to our sponsors for bringing all of you together for the sheer fact of having an opportunity to network and to build community, because that's really I think how we come together and solve the big problems of the day. And I think that by saying that, I hope I'm telling you that I am not going to take a political position today. I'm not going to advocate for any particular plan related to this topic. And I'm going to try to give you sort of a big picture view of it, and then close with what it means for us at Bellin Health as a healthcare provider. So I'm going to start by trying to define what this is, but I first want to just give you a little bit of an overview of who we are. And you sort of heard it in the introduction of what Bellin Health is and where we exist. And we are made up of many parts of a healthcare system, but we also have as the first two words of our mission statement that we do things in partnership, because we can't achieve health and well-being in the communities we serve without many, many partnerships, and that's very important to us. I want to mention just on this slide, looking at the geography and where we are located is Northeast Wisconsin and the Upper Peninsula of Michigan. But more important on this slide are the percentages. And I share this because it's important to think about today, how is healthcare paid for? Who's footing the bill today? And then translating that to the Medicare program, if it is a Medicare for all in the future, what would that look like? It isn't as if all of the funding goes away. The funding still has to come from someplace, right? So today, about 54% of the market is covered by insurance that is either sponsored by the employer or purchased on the exchange. So that's a big chunk of the population. 18% of it is about Medicaid, and about 16% is covered by Medicare. And the 12% of uninsured is actually probably a bit of an overstatement today. It's probably a bit less than that. But the point here is that the lion's share of the healthcare costs are funded by employers. No surprise, right? Many of you in the room, CEOs, managing that as one of the probably single biggest expense items on your budget. Mine too, by the way. So to cover the healthcare spend at Bellin for our own employees is about $35 million. So it's a big number. So Medicare for all, what does it really mean? It's just the latest slogan in a long line of slogans, right? So back in 1935, when the Social Security Act was passed, that actually started the platform for starting to talk about healthcare reform and the cost of healthcare. And that continued on. It continued on into the early 60s and 70s, in fact, when Medicare was a bad word. Medicare was runaway costs. It was too expensive. And generally, the sentiment about Medicare was quite negative in the 60s and 70s. Today, however, it's very different. Today, Medicare is viewed mostly positively. From a healthcare provider standpoint, it doesn't pay well, and I'll talk a little bit about that. But for people who have Medicare as their coverage, they're overall fairly satisfied with it. And the other thing that Medicare has done a better job than private insurance at is managing cost. When you look at their trend line, they do better than most private insurance companies. So think about slogans. We've heard things like universal coverage. In the 1990s, the choice slogan was single payer. We need a single payer system. So today's slogan, Medicare for all, is just another slogan. And you really have to get underneath it and try to understand what does it really mean. In 1972, Canada became a single payer system. And that really started the conversation going in the United States because they're our neighbor. And we watch that and we ask, how is that going to work? And we talk about, well, let's go to Canada and get our drugs, our pharmaceuticals, because they're cheaper in Canada. But then we also talk about people from Canada coming to the United States to receive health care because they don't have access. There is not a perfect system out there. So I just want to read this little quote from Jonathan Oberlander from the Milbank organization. So I think this is really insightful. Reformers' recent invocation of Medicare for All reflects a significant change and undoubtedly an improvement in political strategy. Medicare for All immediately connects proposals for government insurance to a popular, familiar, and entrenched program that already exists in the United States, rather than to a confusing financing label or a mostly unfamiliar and often vilified foreign insurance plan. And I think this is kind of a funny, clever part. Supporters of the metric system can attest to the limits of citing the international precedent as a means to securing changes in the United States policy. Right? There's nothing wrong with the metric system except that it's theirs and not ours. And here we are, the great debate for 2020. You can't turn on the television without hearing about Medicare for All. Those words are thrown out there, but whose plan is the best, and how are we ever going to decide that with all of the rhetoric and all the slogans and all the mudslinging? But what's at stake is our health. And what's at stake is a significant part of our economy that has an impact on all of us. Should we allow private insurers in the market? Or should it just be the government? Should Medicare be mandatory or optional? Should Medicare be expanded by age? And let's start there. All of these are in discussions. And all of these are in the details of those plans. One of our physicians who's very, he's a big reader, and he heard that I was going to be doing this today. And so yesterday he sent me an 81-page document. I brought it with me, actually. It goes through every one of the proposals and the finances of every one of the proposals. We're not going to talk about that today. So there's really two basic models in the Medicare for All slogan lingo. One is the pure model, and the other is a hybrid. The pure model establishes that national insurance program. It generally would not allow any private insurers to exist. Everyone would be covered by this national insurance product. The hybrid does allow private insurers to continue to exist. Now, one caveat, neither of these is really Medicare for All, because in all cases, the Veterans Administration continues and provides coverage for veterans, and the Indian Health Services continues in all of the plans that are being proposed. Elizabeth Warren and Bernie Sanders, they're the pure model. So this is national coverage, no private insurers. Indiana Mayor Pete Buttigieg, my son helped me with that. He said, boot, edge, edge, Mom, just say that, really fast. I said, but I get accused of being Canadian when I say boot. So his plan is Medicare for all who want it. And that's really what Biden is saying as well when he says that he's going to allow Americans to join a new Medicare-like public option, or they can remain in their current plan. So this Medicare word is used because it's familiar and it doesn't cause us to have the hair on the back of our neck stand up like some of the phrases. So it's a friendlier term. Most recently, you heard a lot about Elizabeth Warren's plan. And how much is it going to cost us? It's somewhere between $20 trillion and $52 trillion. Not a widespread or anything. What's also talked about is the number of jobs that will be lost in a Medicare for All program. Something like 2 million jobs. Obviously, most of those in the health insurance space, I would guess. So private insurers in a hybrid plan would have to compete with a lower cost public option. And the thinking there is that in and of itself, that competition will drive costs down. I think it's interesting that 55% of large employers actually support Medicare expansion to some degree. Why would that be? Well, here's why it's a big issue. We are consuming close to 18% of GDP for healthcare. And that has not changed much at all, and it's crept up over time. And it's anticipated, if it's not controlled, to continue to creep up. And we just can't afford it. What's driving this? A lot of things are driving it. And everybody's pointing their finger at everybody else. Insurance companies are making huge profits. United Healthcare, they announced their second quarter profits. They had $3.29 billion in earnings. $3.29 billion in earnings. It was a 12.7% rise in their second quarter profits. There's a lot of money and a lot of profit in healthcare. Optum is their pharmacy benefit management arm. And Optum, their profits are way up. And it's coming from those rebates, primarily from the rebates that the drug companies provide to the pharmacy benefit managers. Those are the rebates that Trump is talking about. When the president says, I want to give that money back, he's talking about taking those rebates and not letting them go to the net earnings line, but rather give that back to the consumers. Insurance companies will point at healthcare providers. There's a lot of waste in healthcare. But the way that healthcare is paid for, primarily today, is on what's called a fee-for-service basis. So you do more, you get more. My CFO is in the room and he always says, ring the bell, and you get paid. Just ring the bell. That's wrong. So the system does have to change and create better aligned incentives. This is what's happening to individuals. So individuals are footing a lot more of the bill today for healthcare, in part because of the introduction of high deductible health plans, but also just in terms of the overall cost of care. So in 2002, and these are national averages, the average household income was about $68,000, and people were spending 13.4% of that on their health care in terms of premiums and out-of-pocket costs. In 2016, income went up to $105,000, but the healthcare spend now was 24.4%. And the projection is, if this continues, that by 2030, income will be $149,000, but more than a third of that will have to be spent on healthcare. What does that leave for housing and transportation and education and food and childcare? It's not sustainable. It won't work. And Medicare for All doesn't really address the affordability. They haven't gotten to that. Nobody's talking about that. Instead, it's just shifting. It's just shifting where the dollars are coming from. So it'll be taxes that will fund it. Elizabeth Warren is talking about taking what employers spend today and just turning that into a tax. And now instead of the employer deciding where they spend that money, what the plan design looks like, how they want to fund their employees' health insurance, they'll just pay that same dollar amount and give up all those choices and let the government decide. That's what national health care will do. And then there's this issue, because as a provider, we talk about this. This is Medicare. Medicare margins have dropped significantly over the years. We lose money on Medicare. It's generally true. Where we make it up is on the private insurance, the commercially insured patients, right? It's just a hidden tax. We're shifting the cost of healthcare from one bucket to another bucket. It is a broken system, but I haven't seen yet where anybody has a really good solution to it. But I do want to show you what is, at least on a small scale, an alternative that I do think has merit. And we always talk in healthcare and in business in general about scale and spread. And try something and figure it out on a small scale. And once you have it figured out, spread it. I think there's an opportunity here. So we've been on a path at Bellin to move from what's that fee-for-service payment system to a value-based payment system where we take risk. We're responsible in that scenario for the outcomes. So you can't just withhold care, because we have to produce high quality and good outcomes for the good of the population. We also have to produce a good experience for the consumer in a risk-based environment. But we do also have to remove the waste. So we have to provide the right care in the right place for the right reasons. This aligns the incentives so that healthcare providers and payers and consumers are all on the same sheet of music. And I'm going to give you an example of what this looks like. So this is a program that Medicare actually started about 7 years ago, I think, going on 7 years ago now. It was called Premier originally, and now it's called Next Generation or Next Gen. And this is what's called an ACO, or an Accountable Care Organization arrangement. We are accountable for the care of a population of Medicare patients. In our case, it's about 10,000 people. There's over 40 other healthcare organizations that are also participating in this program and are also responsible for some of the lives within the Medicare population. The red line is the national average, so that's at the top. On a per member basis, per enrollee basis, what does it cost? It's about $11,500. Bellin's number is on the bottom, and our number is shy of $9,000. If you took all of the Medicare lives, and instead of paying at the national average, you could bring it down to what Bellin's costs are, we would save the Medicare program $161 billion on just this population. $161 billion of difference. I don't believe that Medicare patients are sicker in Florida than they are in Wisconsin or in Texas or anywhere else. So this is definitely a doable program, and it's something that could be expanded, and it would take care of the issue with GDP, and it would take care of the affordability issue, and it would do it in a reasonable, rational, logical way that's been tested, and it works. But guess what? We cannot get private insurance companies to work with us on this. First of all, they're not willing to be transparent with the data. Medicare had to be transparent with the data. They had to show us what's going on with those 10,000 lives that we're responsible for. And not years later, where the data is so old that it doesn't even make sense anymore, but in real time. Help us see how these individuals are consuming healthcare and the choices that they're making, and allow us to work with them to better manage their care. It takes transparency and it takes a partnership, and payers aren't willing to do it. So if we could just get to that point and really partner and bring people together around the cause of bringing down the cost of healthcare, improving our results, because as a nation, we got a lot of work to do when we compare ourselves to other nations in terms of mortality rates, in terms of infant mortality in particular even. Think about that. We're not a third world country, and our infant mortality rates in this nation. Now, in our state, we do very, very well. But as a nation, we don't. So we have a lot of good things that we could be working on if we could get past the rhetoric, get past the mudslinging, and really talk about this in the best interest of our nation. So Medicare for All won't itself improve health. There's the other social determinants of health. There's socioeconomic status. There's the education that an individual has. There's their access to food and nutrition and clean water, all the environmental impacts. They also have a profound impact, but partnering together can solve all of these things. We can work together and we can achieve better health for the people and the communities that we serve. I think we're really fortunate in Green Bay and in Northeast Wisconsin to have the partnerships that we have, to have the Community Foundation focusing on what's best for the community, to have the educational programs that we do, both K-12 and secondary. We are very, very fortunate. And I think that we can be a bright spot in the nation and show our results and collaborate and work together to solve some of these issues. So thank you. And I guess I have to take some questions if you have any. Yes, Dan.
I have a question. So you indicated that Medicare is not a profitable enterprise. Is the accountable care profitable for Bellin?
Yeah, so with the accountable care model, the question is, if Medicare isn't a profitable program, does the accountable care model work? And the answer to that is yes, it works, because the savings that are generated are shared. So while we are reducing on a fee-for-service basis the utilization and bringing down the cost, the Medicare program is rewarding us for that. And I'll explain why. So in an accountable care organization, when you have to manage the health of a population, you invest in different roles and jobs within your organization. So, and I'll use the term navigators because it's very illustrative of what I'm talking about. But you know, if you had a chronic health condition and I had a navigator working with you, that navigator could make sure that you're following all of the behavioral lifestyle things that we ask you to do, that you're taking your medication correctly at home. That person could be checking in on you. In the fee-for-service world, there's no reimbursement for that. So there's no incentive to do that, because all of that cost just adds on to the cost structure. But when you're managing the population, that's an investment in the outcomes that are going to then generate the shared savings. And so indirectly, you get paid for doing the right thing and managing health versus ringing the bell. Does that make sense? Yes, Therese.
Great job, Chris, on a very difficult conversation. But could you comment on the underlying assumption of Medicare for All, that that's free? Just like education can be free. Even those on Medicare recognize it's not free.
Yeah, Medicare for all, and this idea that somehow it's free. It's not at all free, just as education isn't free. So we all know when the educational system wants to build a new school or add some new programs, what happens? We get a referendum, right? And we get that referendum because we're going to be taxed to pay for that. So same thing with Medicare for all. If the government is going to take on the responsibility for funding health care for everyone, guess what? We're all going to be taxed. So in many of the European countries where they have a national healthcare system, their wages are taxed from an employment standpoint in excess of 50%. So we have, what is the Medicare number today, Jim? FICA, what's the withholding? You guys probably know it better than I do. 7.65? Just that number wouldn't even begin to scratch the surface. It doesn't actually today. I mean, Medicare is underfunded today really because of the baby boomers and the significant number of the population that are in that over 65 age group where they just consume more of the healthcare services than the others, and there's just not enough funding for it. Yes.
Are you aware of a lady in Montana called Marilyn Bartlett?
I am not. Who is Marilyn Bartlett in Montana?
She is the administrator of the state's health plan for government employees. And 2 years ago, the state was the plan was going bankrupt. So she negotiated with the local hospitals in Montana. There are only 4. And through those negotiations, she got all 4 hospitals to agree to take 230% of what Medicare would approve for hospitals. And there was no extra taxes to the citizens of Montana.
Yes, do you want me to repeat the question? The question really is related to, in the state of Montana, for state employees, the state was going to be bankrupt. They couldn't afford it. So surprisingly, first of all, this part shocked me. In Montana, there's 4 hospitals. We have 4 in Green Bay. Yeah, which actually might be part of the problem, by the way. So what they did is they went and negotiated with those 4 hospitals to take care of the state employees, and they negotiated a rate of 230% of the Medicare rate, and that makes it work. But just think about that. So remember what I said, Medicare pays us $1. The state of Montana is going to pay the hospitals $2.30. Because Medicare is not a sustainable platform. And that's the other thing that, we have to really acknowledge and agree with, that just because Medicare today looks the way that it looks, Medicare for all can't look the way Medicare looks, because it will destabilize the entire healthcare system in the United States. We can't make it work on Medicare dollars. It won't work. So there has to be a fundamental change to the payment system that goes along with this. Phil?
Going back to the Medicare model that you're working with, the ACO piece, if you could talk about a few other techniques that are used. You talked about the navigator, which I assume is kind of like a social worker, and you hired a lot of them to work with the families that compose the 10,000. And I really buy into that concept. What other techniques were involved?
So and we were talking about it at our table, advanced care planning. So allowing people to have a crucial conversation before a medical crisis happens so that they can say, this is what I want at the end of my life, this is what I don't want. Because in healthcare, if there isn't that directive from a defense mechanism, we're basically going to do everything. And if someone doesn't want that and they articulate that in their advanced care planning documents, then we can avoid a whole lot of spend in the last 6 months of life that really produces no value. So that's one of the things. Medicare has a rule that in order for a patient to go into a nursing home and have those nursing home days covered by Medicare, they have to spend 3 days in the hospital, whether they need it or not. So guess what happens? 3 days are spent in the hospital to make the coverage happen in the long-term care facilities. Those 3 days in the hospital are much more intensive and costly than the days in the nursing home. So that's added cost. So in the program, they waive the 3 days. So a patient can go right from an outpatient hospital visit to the nursing home, and Medicare will pay for it because it's medically necessary. So that's another. And there's a host of things like that in terms of how home health is used and the ability for individuals to access and benefit from home health. So home health you must be homebound in order for Medicare to pay for home health care. And homebound it's a ridiculous definition in today's world, to be honest with you. In the accountable care model, there's no requirement that the patient be homebound in order to receive home health services. And services provided in the home are many times much less costly and also actually more effective. Just a few examples.
You should tell the story that you told at breakfast.
Which
of
one?
The article that you read of the 75-year-old.
Oh, so I read an interesting article, and I can look and see where it was. I don't remember which magazine I was reading it in, but it was, the author is in his 60s, and he's telling the story that at some point in time, I think he was in his 50s, he made the decision that when he turned 75, his approach to his health and health care was going to change. And he goes through an explanation of why he made that decision. That includes things like not wanting to be a burden later in his life, having that date in his mind so that he really lives his life fully to the point of 75. And at 75, he is not advocating for euthanasia or any kind of, intervention to end his life. But what he is saying is that I'm no longer after 75 going to get my cancer screenings. I'm no longer going to take antibiotics for infections. I am going to allow nature to take its course after 75. So in our country, we prolong life to, in his mind, in the article, an extreme. And he's advocating for us to think differently about those later years in life. And he says, I want my children to be spending time with their children, not feeling compelled to take care of me. Because if they're taking care of me, I'm taking away from my grandchildren, and I don't want to take away from my grandchildren. His children, however, feel very differently about it, and they don't ever want to let their dad go, and so they feel that they will be setting a great example for their children about caring for others and the value of our elders, and that he will deprive them of that. So it's an interesting and fascinating article because you can see all viewpoints, and it really comes to your own value system and how you ultimately resolve in your own mind how you feel about the article, but it's an interesting one. Phil?
Yeah, it's okay for Dean to ask that question, but for a lot of us.
75 is far too young, by the way.
Another the big experiment between Buffett and Amazon and Citigroup.
Yeah.
Do you have any insights into that at all about how that's going to ultimately evolve?
Yeah, so this is an interesting question because everybody's getting into the healthcare space because healthcare spending is going to grow by $2 trillion in the next 8 years. So it's attractive, right? So Google and Amazon and everybody wants to be in that space now, and Apple. And then you've got this Haven group that is saying, we're going to come together and we are going to innovate and solve what's driving the healthcare spend, and we're going to manage it differently ourselves. I don't know how effective they're going to be at it. I'm interested, and we have no one to blame but ourselves from a healthcare provider standpoint, because when you leave the door open because you're not taking care of things, someone else is going to come and do it for you. Whether it's going to be the government imposing Medicare for all or some other system on us, or whether Google and Amazon and Apple are going to come and show us how to get it done. Somebody's going to show us, and I guess from my perspective, we're going to watch and learn. I'm confident that for us at Bellin, we have been practicing value-based medicine for decades. It is in our DNA. It's how we operate. I just want to know what the rules are. So tell me what the specifications are. Tell me what the rules are, and I'll do it. You know, our team is ready. We will design our services. We will follow the rules, and we will stay committed to improving the health and well-being of the people in the communities that we serve. And no rule that could come down could ever make that wrong. So we feel that we have a very good strategy and a very good plan going forward. But we don't like the chaos and the uncertainty, and it makes doctors and other healthcare providers really, you know, it adds extra stress, I guess, that is unnecessary. So to the extent that we can shorten that period of uncertainty, that would be great. Yes?
Chris, you mentioned that the private insurance world just isn't playing along and being transparent for the ACO model. Is there, I know that you and ThedaCare have the Robin plan, and I was about between Robin and the Common Ground. I know you were an early partner with Common Ground, that health product down there. Is that what that is? Is it a network? And will Common Ground give you that information? Is there a way to do that locally with private insurance to mimic the ACO model?
You know, everything is possible if people want to do it. Robin and Common Ground for us is very different. Robin is the health plan that Bellin and ThedaCare partnered with Health Partners to offer in the community. So we actually, in that one, we take risk, and what we collect in premium dollars, we need to be able to manage the health of that population. It's very much like an accountable care organization type model. And we have access through that to all of the claims data and all of the information so that we can best manage the care of the population that Robin insures. Common Ground is a bit different than that. Common Ground is a cooperative, and while we are a preferred provider within that network, we don't have the same level of access to the data through Common Ground that we have through our Robin program.
Is that something in Common Ground that you try to get that out of them? I mean, I know they're a cooperative, so it's a different ownership model. Would that be something they would go along with?
Yeah, I think that it's a smaller organization, so the conversations obviously are different and they can be accommodating. Although I will say that one of the issues for a smaller organization like Common Ground is analytics are really expensive. Both the systems to track and report on the analytics and the people who know how to use that data and work through that data to actually draw conclusions out of it that are actionable. So that's part of the challenge. The bigger health systems have more capabilities in that space.
One more question.
Okay, one more question. Therese?
Well, just a comment, you know, there are a lot of experiments in the commercial insurer space, like Prevea 360 is with Prevea and HSHS, that really are taking the ACO, Accountable Care Organization model, to look at how do you manage the total cost of care, what are the levers that you can use, and in the commercial space, I agree 100% with Chris, you have much better access to that data. You can see what's driving it. So if you're working with an employer that can look at even a self-insured employer, look at their claim spend, and you understand what programs can start managing that. That's really the benefit of managing the total cost of care. There are things that we can control and things that we have no control of. Can't control the drug company pricing, but we can control utilization. So total cost is about unit cost times the utilization, and that's the piece that I do think there's hope in that.
Yeah. And Father, I know that when you did your prayer that you didn't quite know just how apropos it was going to be about two or more being gathered and God being with us to try to solve this problem. So we need all the help we can get. So thank you very much, everybody.
So I want to thank Chris for her thoughtful and thought-provoking presentation. I think we're all going to stew on that for a while. So if you'd like a copy of today's presentation, please see Lisa Gray. Lisa, if you would identify yourself, and we can get a copy to you. Please join us for our next CEO breakfast on December 10th at the Butamore Country Club in Appleton. Mary Goggins, president of Encapsis, will present on the topic of Grow Your Business Through Open Innovation Partnerships, a case study. We hope to see you there. Have a great day.